Is it recording? Yeah. All right. Good day, everyone. This is Glenn. My sister, Rebecca Berman, is unable to join us again this week, but hopefully we will see her next week. I want to welcome everyone today. We have a bunch of really interesting things to talk about, and I look forward to your questions. So to start out, let me just share my screen. All right, so we're actually this isn't a great chart that I'm looking at. This is the projection of the number of total new cases that there were in the last or daily. So right now, this is the best projection that we have between around 430 and 700,000 new cases per day. On this long-term projection, I wouldn't pay much attention to this downward trend because we really don't know what that's going to look like over the next month or two. But what we do know is that we have leveled off a little bit over the last week or two. Or not week or two, let's say, from last week, the rate of growth has not been as large as it had been previously. So we were a little bit higher this week. I believe last week we were at approximately 455,000 new cases. Now we're at approximately 465,000 new cases in the last week. What this means is that we're still out of control, but we're no longer accelerating as fast as we were, which is good news. So it's kind of as if we were on the highway going at like 200 miles per hour, but last week we were still stepping on the gas pedal and going even faster and faster. But then over the last 7 days or so, we've since then now taken our foot off the gas pedal, and we're still going crazy fast, and it's not under control in any way. Lots of people, there's lots of excess deaths, there's lots of hospitalizations, lots of people are getting sick, but we're not accelerating anymore. So that's some good news. All right, so there is wide variation, but before I get into the variation across the country, I'll go into the high level view across the country. So the number of tests are continuing to increase, and so that's good. We're testing more people at a national level. The number of cases that have been diagnosed have plateaued a little bit. Again, so if you look here, the daily diagnosed number is a little bit, it's going up and down roughly around 70,000 in between. The average over the last week was between 65 and 70,000. But these are the diagnosed cases. Again, this is daily diagnosed on July 25th, so that was yesterday, was approximately 65,000. But again, let me go back to the previous slide. So again, the total number of new infections was estimated to be far, far higher. So we're not doing a good job of diagnosing. So we don't really know if we're actually plateauing. This could just be some noise that we're looking at here. We are looking, I'll get into some details with Arizona. There are some spots that are going down a little bit, which is great, but other places are increasing still. So current hospitalization rates. So we are at the same hospitalization rates that we were at the peak back in April. So we've hit that point again. And hospitalizations are still increasing in places. The death rate, as we talked about, lagging. It's far less than what we had previously, but I'm going to do a deep dive into that tonight. There's a lot of interesting issues with the reporting of the deaths. In terms of where the cases are occurring, so right now, the vast majority are occurring in the South and then the West. And even within the South and West, there are really hot spots in some specific areas. The Midwest seems to be doing quite a bit better, and the Northeast is doing quite well. So you can see that these are the hot spots now that we're looking at. So Florida, Texas, California are clearly have the most number of actual cases. I tend to prefer to look at it by the cases per 1,000 or per million. This is hospitalized. Let me go back. So this one. So this is cases per people, because then it normalizes it, because otherwise it's hard to compare a big state versus a small state in terms of the numbers that they're getting. And so when you look at it this way, you can see that the numbers that we were looking at before in terms of the hotspots, Florida, Texas, and California, are still hotspots, but now there's a lot more of them. So you'll see Alabama has quite a lot now. Georgia, the South in general, is doing quite poorly here. Up through the Midwest, there's a couple states that aren't doing that great. So Iowa, Missouri is down here, is not doing so great. Montana is not doing so great. Montana's up here. Montana's doing great. All right, so Arizona is interesting. Arizona is has gone down from previous weeks, and so you'll notice here that they're no longer the dark red, and that they're still red. They still have some serious issues over there, but they're not reporting as many new cases, hospitalizations, or death. In fact, let me jump to that for a second. And so this is really interesting. So Arizona, they haven't completely shut down. It is summer, so there's no schools in session right now. They have closed all bars, they've closed all gyms and stuff like that. They have mandatory masks wearing, and people are concerned because they've been reading the news in Arizona. But interestingly, the number of cases have been going down. Unfortunately, the number of tests have also been going down. So and the test rate, does it have the positive test rate here? No, it doesn't. The positive test rate is very high in Arizona. And so it's really out of control still there. We don't know how accurately this is represented. This could simply still be an artifact, but interestingly, the hospitalizations seem to have come down a little bit. And so I do trust this a little bit more. There was some issues with the reporting of hospitalizations in some states that, if you recall, the Health and Human Services took the surveillance responsibility away from the CDC for COVID, for some aspects of COVID, around a week or two ago. And so since then, it's hard to interpret some of this hospitalization data to know if it's accurate or not. But it's intriguing that this is starting to dip a little bit. But I'll go into Arizona a little bit more as we go into this. These were the reported deaths. And so the reported deaths don't look as bad as we would have expected, given the huge number of hospitalizations and cases. But so I will get into that in a little while. In contrast, Georgia, so Atlanta is a hot spot there, but not all the state is hit at the same levels. So they're rising dramatically again in terms of, so they're doing a great job in testing, but still not enough. Their cases are rising still quite a lot. Their hospitalizations are rising quite a lot, but their deaths are not rising very much in terms of what they're reporting. So I want to dig into this a little later as well. This map, do I hear a question? Nope. Okay. So this is looking at hospitalizations, and so the hospitalizations are still quite large in a bunch of different states. And so this is, so if you see California, Texas, and Florida, but again, as we saw on the last slide, when you normalize this, then you see that the rates of at least infection are not so different across the states. So Louisiana, Alabama, there's some other big ones, Arizona, are still producing a lot of cases and hospitalizations, but because there are less people that live in those states, they're less populous. On a slide like this, they're going to appear to be less just because it's a smaller state. All right, one other thing I'm gonna just point out, so New Mexico here. So look at New Mexico, it's kind of like in between, wedged in between Arizona, or let me show, this is a better one. So New Mexico is wedged in between Arizona, Texas, and Colorado. And so you would think that New Mexico would be at really high risk of getting people who are just moving around from these different states and traveling through, that would increase their spread. But when you dig in on Arizona, on rather New Mexico, and compare it to Texas, Arizona, and Colorado, you see that Texas is doing poorly. Both their cases in red, which is on this axis, their cases are rising dramatically. Their reported deaths are rising dramatically. Arizona is also doing quite bad. Their reported deaths are rising. Their reported cases are dropping, but again, I don't know what that means. It's probably an artifact. I do think that they're doing better, but this is, I think, an artifact because they're not testing enough. But Colorado is still managing to keep it somewhat under control, and New Mexico is doing a fairly great job. So, I mean, they could be doing a lot better relative to their size. If we look over here, they still have a number of roughly 148 new cases per million, which is not amazing. But considering the geography, the neighborhood that they're in, it's not as bad as they could be. All right. Any questions so far? Okay, great. Let me jump into, while I'm just looking at the average across the states, let me jump into some websites. All right, let me look here. All right, so first, yeah, so I shared with you the projections that I shared a little earlier. Again, don't pay attention to this stuff over here. This is hard. It's not based on anything. But yeah, this big thing over here is what I wanted to show. In terms of the dashboard, how we're doing. So I like this website in particular. I've shown it previously. This is the covidexitstrategy.org. And so it shows that the Northeast is doing quite well. The Northeast would be looking exactly like the South and the West right now, except, let me just keep people on mute. Okay, so the Northeast would be looking exactly like the rest of the country right now. The only reason that it's green, and there's only a single reason why we're not seeing more cases in the Northeast, and that's because of test and trace. So we're continuing to physically distance, but we're doing the same exact physically distancing as in Arizona, not much more. They're doing a little bit more now because that's how they're starting to get it down a little bit. But we're really not doing much more than that in many of these states. The primary difference is that for every positive test that's recorded, it automatically triggers the whole system of contact tracers. And on average, there are, let me go to the test and trace dashboard. So in New York, there are on average around 13 to 14 contact tracers per positive test. So if someone gets a positive test result, they send out a team of people to find who they may have exposed in the previous few days, who did they catch it from, and they test everyone around that area to among rather the people who were identified, to try to identify any positive cases, to quarantine them, to make sure they isolate themselves, and to warn anyone around them that they might have been exposed and to go and get tested. So this is huge. Contact tracing and testing works. The rate of the test results, it's because they're testing so many people, only around 1 to 2% of the tests are coming back positive in these places. So New York, it's coming back 1.09%. So roughly 1 out of every 100 are coming back positive. So this is enough at these levels. Here in New Jersey, it's roughly 2%. So 1 out of every 50 are coming back positive. New Jersey's actually doing a little bit worse. I've been tracking them a little bit. So the ideal number of contact tracers, the range is it's supposed to be 5 to 15 contact tracers available for every new positive test. And unfortunately, New Jersey is under that a little bit. We're down to 2.7. That's because we've had a few more positive tests over the last week or two. And so it's pushing our numbers. We should be hiring new contact tracers. We're really at the lower edge of that limit there. So it puts us at risk that our caseload might start to rise again in the next few weeks. But right now we're doing okay. This is more of a logistics thing. We should be hiring more people. We need to be doing more testing. One thing that I've heard is it might be hard to find testing in New Jersey and some of these other places. There's a limit in the number of tests and the capacity available. And so that puts a strain on the whole contact tracing system, because if it takes you a few days to identify if you're positive, then that's a few days that the contact tracers have wasted in terms of identifying all the other people that might have been exposed during that time. So it's a problem, but it's a logistical thing. If we had more money to invest in it and hired more contact tracers, this would make a big difference. And frankly, I mean, our economy is doing better than if we were locked down. And so, I mean, it seems like this would be a worthwhile investment. But then if you come to somewhere like Florida, so Florida has on average less than 0.2 contact tracers per positive test. So that means that you need at least 5, 6, 7 positive tests for one contact tracer. So they've essentially given up on that. There's no way that they can go and identify anyone that these people came into contact with. It's kind of like they're not doing any contact tracing at all in that sense. And so that's the essential reason why the Northeast looks green and yellow and the rest of the country does not. That's the one reason. That was the whole point of shutting down. One of the main points. One point was because of the uncertainty. We wanted to shut it down to make sure the hospitals could deal with the things while we better understood it. But then one of the major points of the shutdown and why we kept shut down for so long was to increase our capacity for testing and tracing. And so the Northeast used that time effectively to do that. The South and the West did not, and much of the other parts of the country did not either. And so it's really just a waste. We're in no better shape now than we were several months ago. All right. You notice this number, 4 million cases. So approximately 4 million cases have been reported so far to the CDC, roughly 4 million. If you look at the projections of the total infected, the best estimate is that around, I would say 35 to 49 million, maybe even on the higher side. So maybe like 40 to 49 million have been infected at this point. So that's a lot. And so when you compare this, 40 to 49 million likely to have been infected in the United States, back again to 4 million, that's a huge difference. We're really not capturing a lot of people. And again, that's because we're not testing enough. And that's why we're seeing what we're seeing here. It's simply a testing issue. I mean, I can't say it any more clearly than that. We knew it. We had the capacity. We could have made the capacity more. The federal government has emergency powers. During war times, we use these to take over the manufacturing plants to do what we need to do to get it done. And in this case, we didn't do it sufficiently. There are still insufficient tests, and this is what you get. It's poor management, poor coordination. It's as simple as it is. Other countries are doing quite a lot better than us. So for instance, when you look at parts of Europe, so France, Germany, a lot of these countries had earlier spikes when no one really knew what was going on, but now their economies have largely opened up again. And so now they can go on vacations and they have the freedom that we wish we had, but they don't have the cases or the deaths because they opened up after the numbers had come down. And so that enabled them to now contact, trace, and test. So the same way that we're doing it in the Northeast of the United States, that's what they're largely doing in much of Europe. So when you look at Italy, Netherlands, I mean, look at this curve. Italy did really poorly at first, which they didn't know what was going on. They locked down because they realized they had to, but it was almost too late at that point. But now they have it under control. I mean, obviously it's not perfect. There's still 230 cases a day that are identified, but this is what control looks like. This could have been us, where you get it down to hardly any cases on the country level, but it's enough that contact tracing and testing are sufficient to keep it down, and you keep the death rates down. You keep all the serious at-risk patients from getting sick. When you look across Europe, they're doing well right now. They're enjoying their summer. I've been talking to friends in Europe, and this summer is not super different than any other summer. They're still going on their vacations. They're still doing the stuff that they're doing, but they're really not seeing the terror and the hospital scenes that we're seeing in the United States. Although we're not really witnessing it on TV right now. I think that's not helping with the situation because in the United States, we're not aware of what's going on. The United States, in contrast to what I just showed you, we had our initial bump, and now we're just rising again, just continuing to rise. Okay. Let's see. Yeah. All right, let me go back to another. So this is just another dashboard, same as what we were talking about. Let me go back to what I was just sharing earlier. All right, are there any questions so far? I don't know if I can unmute all. If you have a question, please unmute yourself. And here. Nope, all good? Okay, good. Let me share again.
You still in front of the fire?
Glenn,
Yeah.
I have a question.
What's up?
How about Sweden? What do their stats look like? And what happened with Israel that they sort of imploded for a bit?
Oh yeah, those are good questions. Let me go back to that for a second. All right, so Sweden has been doing a little bit better, actually. I don't know how their policies have changed. I think they were over here, yeah. So Sweden has come back down to where they were. If you recall, they had sort of had this slow burn that they allowed themselves to do, where they did close, like we assumed that it was laissez-faire, totally hands-off, but that's not actually the case. They did close their colleges and their high schools and stuff. They did have major changes there, but they did leave open some of the restaurants and but even with the restaurants, they only allowed like half capacity, and so they still did things, but it wasn't nearly the full lockdown that the rest of the world experienced, or at least the Western world experienced. Then you see that it rose a lot again, and then started coming back down. Now the numbers are a little bit lower than where they were back in March and April. It's still higher than what we would have wanted, and it's much higher than what we're seeing in other countries. Like, so for instance, they never did bring it back down to what we were seeing in Germany, France, and these other countries. And so there are still excess deaths and excess morbidity as a result. But they're able to do this. They realized it was communicated, I think around this point actually, somewhere up here, the country had a soul searching. The federal government of Sweden made the determination that they had failed in their approach, and then were reevaluating what they were going to be doing because they were unhappy that the curve looked the way that it did. I don't know what their policies have been like since then, but you can see a rapid decline, and so I'm assuming that there were different changes in policies that they've done other things. I don't know if that's the case though right now. For Israel. I think I saw them over here. So Israel's in red. So Israel is out of control. I remember when it first was starting back in April, there was a big debate over herd immunity, and I'll talk about that a little bit more today as well. But this debate, a lot of countries, in particular, there was a famous researcher in Israel who said, "Oh, there's lockdowns are stupid, they're irrelevant. The course of this disease at the population level is roughly the same in all places, and within around 3 to 4 weeks, it'll be over everywhere. And so lockdown was not necessary in Israel because 3 to 4 weeks, the curve would have looked identical." And then you couldn't really prove him wrong because, of course, the lockdown worked, but you couldn't really say that what it would have been without the lockdown, but now you can. And so now we see a rapid rise in cases, and clearly the ones who said not to be concerned early were wrong. Although some of them are still saying it, and I'm going to be talking about that a little bit later as well.
And Glenn, wasn't it related to the kids going back to school as well?
That was part of it. They've tried to reopen the economy, and so it's a bunch of things related to that. And so this is what you get. It's tough. It's not easy to reopen the economy during a pandemic, and that's just the way it is. We don't have to like it. It's just that's the way it is. But there are ways. Like I keep on coming back to this. If we had put it under control with testing and tracing, then there are ways to do it so that you can reopen the economy and then, but have very little cases. So one other thing I wanted to show you is I've been referring to this a lot. This is mobility trends. And so this comes from Apple, I think, where they track movement using their cell phones at the population level, just on average, looking at averages across countries, across geographies, to see how people are going. I think, you know what it is? I think it's their mapping program, how often their mapping programs are used and the distances that are traveled. And what they found is that, so this was the average before, pardon me, the original lockdown. So this was January, February, March. Then we locked down. You see Italy had this first crazy lockdown where everything just stopped very quickly. Then they had a couple months of very, very little movement. And so this was way less than normal. Germany was in purple. Germany locked down, but then started opening back up in March, or I guess early April, slowly starting coming back up. And so you see, the key thing I want to point out here is that all these countries dropped to some degree. Here's United States in gray. And so we looked at Germany's curve pretty well. And here we are coming back up here in terms of how our economy is doing. But the difference, and so this is typically a pretty good metric, a good marker in terms of how much people are moving around. And that's a good marker of how much they're doing transactions. Are they going to the supermarket? Are they going shopping? Or are they going on vacation? This is reflected in terms of mobility. And so the mobility now is actually even more than what it was, than what you would have expected versus earlier, back in January, February. I mean, people move around more in the summer, but it seems quite a lot more than the baseline. So I'm not sure how they normalized it. But the interesting thing is that the United States is roughly the same amount of mobility as Italy, as Germany, and a little bit more than UK, but roughly the same as these other countries. But because we failed to get our caseload under control, we are killing people off by the thousand here. Whereas in these other countries, people are not dying and they're not having the morbidity. That was all a failure of federal government choices. And so the economy is the exact same. If people said, oh, we should keep the economy open, our economy right now has the same, if not less, freedom than in Italy, in Germany, UK, other European countries. We have our hospitals here are full in many states in ways that they are simply not in these other countries. And so that's what I wanted to point out there. All right. So that's that. All right. Let me come down to this. This was an interesting question that arose during the week. The question of aerosols, and it keeps on coming up. Do masks help? And so early on in the epidemic, we weren't sure if masks even helped at all, but we did know that masks needed to be used in the hospitals and among the caregivers. And there were a shortage of masks versus what we knew what we needed to expect. And so as a result, the public health community was telling people not to get masks because we were sheltering in home. Don't get masks. We need it for the people, for the healthcare providers. Then, as more and more research was done, we realized that masks do play an important role. They don't have to be the medical grade masks. Just cloth-based masks are sufficient. And what masks help with primarily are droplets. And so then this question has come about, well, how much of the virus is spread through droplets? How much are spread through aerosols? And how much are spread through physical contact? As time's gone on, now it seems like there's much less spread through physical contact. So for instance, if you order something from Amazon, there's a lot less concern right now about making sure the box is not contaminated and that kind of stuff. That we think that that's a little bit safer. Aerosols we've increased our concern about aerosols over the last couple of months. And so with aerosols, we've been looking at this a lot more, and there is definitely strong evidence that there is spread from aerosols. And aerosols, what makes an aerosol is that it's like a droplet of when the virus is spread, but it's much smaller than you would typically see. And so this makes a difference for two reasons. One, the size of the particle. If a particle is large, then it doesn't stay in the air as long. If it's like a droplet, then it just drops very quickly. So you could be 3 feet, 6 feet away from someone, and it's very hard for a droplet to reach that far just from physical distancing. If it's an aerosol, then that's so light that it can stay in the air, and you could be coughing and the aerosol could go across the room. And so 6 feet might not even be enough for an aerosol. And so the question is, and so with aerosols, one thing that a lot of health researchers are saying now is that aerosols have more to do with the person, with the patient, than with the virus itself. And so when you look at different respiratory diseases, on here we're looking at, on this top one, this is up here the size of the droplet. And so this is a large droplet, and this is a very small droplet in terms of how. And so the difference that makes is that if it's a large droplet, typically it only makes it as far as the upper airway. So maybe your nose filters that stuff out, and the upper airway doesn't go very low. But then as the droplet size gets smaller and smaller and smaller, it can penetrate far deeper into the lungs. And so when you compare on the top one, this is patients with tuberculosis. They've been measuring this for years to see how much aerosols are produced there. And then the bottom one is patients with cystic fibrosis who are infected with this other disease, which I can't pronounce. But what you look at, the key takeaway here is that the distributions of the particle sizes are roughly the same. I mean, they do differ a little bit, but they tend to peak around this value, so 2.1, 1 to 1 or so. And so the distribution is roughly the same, which leads a lot of people to think it has more to do with the person than with anything unique to coronavirus. And so that means that most likely the distribution of coronavirus particles are likely to be this too. And so masks are much more likely to capture the larger particles and much less likely to capture the lower particles. Another way of looking at this is the particle size that's generated from coughing versus through breathing. And so this, of course, makes a huge difference because a lot of us have been using a cough. I mean, we shouldn't have been. But I know that some people have been using a cough as sort of like a indicator that they're sick and we should stay away from them. But then people who are breathing without coughing, who are asymptomatic, we're like, oh, we don't have to maybe have our guard up as much with them. But the reality is that when you look at the particle size, coughing actually produces much larger particle sizes. And so in some ways, the coughing is safer. It's not safer in any way. Let me not say safe. In some ways, it's at least the particle size is bigger. So physical distancing is more effective, and wearing a mask is more effective because it can get the particle sizes that are bigger more easily. Whereas from breathing, you see that the vast majority of particles that are spread through breathing are actually much smaller than even from coughing alone. And so breathing actually aerosols. And again, the aerosols are bad for a couple reasons. They get into the lungs and go penetrate much more deeply, but also they're less effective with the masks. The masks are still definitely effective. They're hugely effective when you're talking about particle sizes of around this size, but when you're talking about much more small aerosolized particles, what they really have the most impact on is if someone is breathing and they're asymptomatic and so they don't know that they don't currently have symptoms and that they're infected. If they wear a mask, then it prevents them from spreading their aerosols out as much because a lot of it is captured. Some of it goes through, but a lot of it is captured. So it is actually the way that it's having its benefit is mostly for people who don't know that they have coronavirus. It prevents them from spreading it to other people. The ones who are wearing the mask to prevent getting it, it has less of an impact for that perspective because the aerosols they're really, really small. They can get through a lot of the masks. And so this again is the reason why the masks are not a panacea. Physical distancing is at least as important as wearing a mask. Being outdoors is way more important than being indoors because aerosols are spread by the wind very easily. They're very light or easily blown away. And so being outdoors is much more important. But again, we still have to take this very seriously, and the masks aren't the cure we were hoping they would be. They are far more effective than not wearing a mask for the reasons I just described. Again, the two main reasons being that they do stop the larger particles, and they do take off a percentage of the aerosolized particles among people who don't realize that they're infected. But at the same time, they aren't a cure. It's not like they're a shield that prevents infection. They prevent it to a degree, but they don't eliminate it. So we still have to be on our guard with physical distancing and these other things. All right. Any questions about that? No. All right. One thing I wanted to talk about, this has been interesting, symptoms, talking about symptoms a little bit more. So there's a study released by the CDC, I think this was in the last week or so, and this was looking at, they followed up on people. I like this takeaway, but I'll dig into it a little bit more. But one of the key findings was that roughly 1 in 5 previously healthy young adults weren't back to their usual health 3 weeks after testing positive. So it's a persistent illness in a lot of people. 3 weeks is still a short amount of time, particularly now that we know there are people who still have symptoms after maybe 3 months or more of having the disease. But I wanted to dig into this because it was still kind of interesting. This is breaking it out. It's hard to see. This is breaking it out by type of symptom. How many of them were still sick around 3 weeks later, so around 14 to 21 days later. So fatigue, among patients who reported a symptom of fatigue, so that was approximately 70% of patients reported fatigue as one of their symptoms. Around half of them were still having fatigue after 3 weeks. These persistent symptoms are even that, my point in preparing this is to say that we've been looking at mortality as a primary issue, but morbidity is a serious issue too. Some of the symptoms do go away, and I'm still trying to track some of the longer term symptoms, people who are still have symptoms 2 or 3 months after, and then even people who have symptoms, then the symptoms go away completely, and then the symptoms come back, let's say in 2-3 months later. This one right now, all we're talking about today, is just the proportion of symptoms that are lingering in the acute infection. And so these are, you can see that there's wide variation. Body aches seem to go down a lot. Headaches go down. So approximately 2/3 of people report having headaches during as one of their initial symptoms during the first week. But then 3 weeks later, maybe 1/4 of those people who originally said that are still reporting headaches. Chills, so fever goes away dramatically as a symptom. So it's an early symptom in over half of the people, but then only a fraction of them still have fever or chills 3 weeks later. Gastrointestinal involvement is continuing in a lot of people. Diarrhea continues. What is this? Maybe 1/3 of the people are still continuing to have diarrhea 3 weeks later. Congestion, nausea, some of these other gastrointestinal things are continuing. Other things like chest pain. There are cardiovascular outcomes associated with this. And so it's interesting that chest pain is a symptom that people have, and it's around, what is it, like 1/4 of the people here look like they're having initial symptoms of chest pain, and that among people who do have initial chest pain, that seems to persist among quite a large percentage of them. But then there's also neurological aspects that we found. And so some of the neurologic symptoms actually seem to increase over the course of the 2 to 3 weeks. I can jump into this a little bit more. I won't spend too much more time on this. I'm sorry that it's so small. But so basically the way to read this is among women, so here 61% of women return to health into their regular normal health within 3 weeks. And almost 40% of women were still not back to their normal health after 3 weeks of infection. And so that's quite a lot for a disease. This is really an illness that knocks a lot of people off their feet. For men, it's around 31%. We're not back to their full health. It varies a little bit by age. So roughly a quarter, 26% of people under the age of 35, we're not under, let's say 18 to 35, because we know kids are very different who are under the age of 18. But so among people who are who are between the ages of 18 and 35, it's roughly 26% of them still have symptoms after 3 weeks. Among 35 to 50-year-olds, it's approximately 32%, and almost half of people over the age of 50 who get infected with COVID and get symptoms still have symptoms after 3 weeks. So this is a lot. It really knocks people off their feet. Among different ethnicities, there seems to be some variation. Among whites, it's around 38%. Among blacks, it's around 43%. And then it goes down among other races who are non-Hispanic, so Asian, some other ones. The sample size was quite small, so it's a little bit noisy there, but it suggests it might be a little bit less. And then among Hispanics, it's around a third. Let's see, there are some other interesting things I found. The more medical conditions a person is diagnosed with, the more it knocks them off their feet. So if someone has 3 or more diagnosed medical conditions, 57% of them are still having symptoms 3 weeks later. Whereas if there's no other major illnesses that are diagnosed, then only 29% of them still have symptoms 3 weeks later. When you look at specific medical conditions, so hypertension is around 50% 3 weeks later, obesity 55%, psychiatric illness for some reason it's unclear is 53%, but there is neurologic involvement. People who have asthma as a pre-existing medical condition have 36% of them continue. Diabetes, around 43% continue to have symptoms 3 weeks later. This one, so immunosuppressive conditions, so this might come about because of cancer might cause that. People who have organ transplants, other reasons for immunosuppression, rheumatological diseases, you would suppress the immune system. These types of things, 60% of people still have symptoms 3 weeks after the illness. Some of these autoimmune conditions, blood disorders, around 50%, kidney disease, around 57%, COPD, 43%. You can see, so some of these, it's really interesting. And it's so fascinating that it does vary so much by the number of medical conditions, but we need to take this with a grain of salt because the numbers here are really, really small. And so it's a little bit hard to interpret. So you would expect wide variation. So I wouldn't necessarily interpret that the variation that we're seeing is necessarily statistically significant, let's say. This was just this one report that came out of the CDC. All right, so that was that for that topic. I'm gonna go on now to talk about, I'm calling it a cult, but so this guy, I don't even know how to pronounce his name, Ioannidis, let's say. So he is a guy, he works over at the, I think it's UCLA. I forget where he works, but he's an epidemiologist, but he's not a good guy here, and I can say that just outright. And the reason is he thinks he's doing good, and what he did early on is he took the Diamond Princess, an early analysis, and he was afraid that if we locked down, it would do more harm than good. And so he was trying to save lives and save the economy by saying we should not lock down. So back in early March, he estimated that there would be only around 10,000 deaths from coronavirus from the pandemic. And so from the US epidemic of coronavirus, there would only be around 10,000 deaths. And he was so convinced that this was the case and that having a lockdown, he was afraid, would not only harm the economy and then keep people from going and getting diagnosed from cancer and so they'd have cancer and it would just progress with that diagnosis. and all these other bad things that happen. You'd have depression and substance abuse and all the other bad things that would happen that we worried about with the lockdowns. He was afraid of those morbidities and mortality. The problem was he took it too far. And he used this one analysis, he misinterpreted the analysis. So the early review of the Diamond Princess, that again, this was that cruise ship, that early cruise ship, was that there were not very many deaths out of that, and the morbidity was low. But that was an early publication, and a lot of people died many weeks after being on the Diamond Princess and after that study had been released. So he didn't capture the full results of the study, and so his initial estimates were way off. So again, he said 10,000 deaths. We're now over 150,000 deaths reported, and I'm going to get to in just a few minutes more details about what the deaths are and that the reporting of the deaths. But he got together a group of other epidemiologists. None of them really famous big guys. They're not mainstream people. Two of them are on this list of who he included. He reached out directly to the President of the United States and to the White House and sought meetings with them to say, don't be fooled by the epidemiologists. They're over-exaggerating the severity of this disease. You don't have to worry about the severity. You don't have to worry about the deaths. They're not going to be very much. And so they put emails together. They were blasting the White House. There were these two other people that were included in this small group that we're talking, and they vehemently disagreed with the conclusions. And these people were from Yale, Sten Vermund, and Arthur Reingold from UC Berkeley. And Yale and Berkeley do have good epidemiology programs. UCLA does have a pretty good program too, but this guy is not someone that I would want to take classes from based on his conclusions here. And so anyway, so what they did is they were responsible. So he produced one of these early meta-analyses. I complained about it in previous weeks that it was just not conducted well. He was using like Iran with tiny sample sizes as the primary driver of an estimate of why the infection fatality rate would be so low. I'll just go back so in previous weeks, I had shared with you this idea that there were a few meta-analyses out there. There were the Meyerowitz-Katz meta-analysis that was suggesting that the infection fatality rate was approximately 0.64%. So from the beginning, even from the very close to the beginning, one of those first analyses that indicated that as many as 2 million people could die in the United States from this infection, that was based on this number. It was approximately 0.7, so 0.7% estimate that we would see that infection fatality rate that would have produced roughly 2 million deaths if 80% were infected. It varied, and so this other person grew well, assumed it was a little bit bigger, but using a different methodological approach. But here's this guy, Ioannidis, I don't know how to pronounce his name, I'm sorry, who was predicting it was 0.25% and likely to be even less. And so it turns out that when you look at the CDC, when their scenarios they were using, their best case scenario was 0.26%, so which was extremely similar to what we're seeing from Ioannidis. He was effective at talking to the right people to make the CDC use those numbers. And that was far different than the Meyerowitz-Katz numbers. But now the CDC over the last week or two has quietly changed their numbers and are now using 0.65% as the infection fatality rate best estimate. But the reason I'm bringing this up is because they played a huge role and one of the reasons that we didn't lock down as fast as we should have. The epidemiology community at large, the scientists who focus on infectious disease epidemiology were saying we should lock down. And because of this small cohort of people, with the two exceptions I said, they really pressured the federal government to not lock down. And in some ways, I think it's a fair assessment with the number of deaths that there's been. The difference in deaths between the 10,000 and the 140,000, so that 130,000 deaths that we're seeing now, that I think he grabbed some of that responsibility for that, because this was not an academic exercise. He was pushing hard for this, and now we have all these excess deaths. It brings me back to what I was saying earlier when we compare the work that, rather the course of the epidemic in the United States versus Germany, Italy, Netherlands, all these other European countries, how they're open now, they have it under control because of contact tracing and testing, whereas the United States is out of control and we're continuing to accumulate all these new deaths. That's because of these people working with the federal government, and the federal government, of course, takes a huge amount of responsibility for this too. They were the ones who were ultimately making the final decisions. But these were the folks who as the scientists were sort of advising the federal government. And so it's good to see their faces and their names. It's good when people make mistakes that they be held responsible. So I just wanted to bring that up. Another question that's come up is this question of herd immunity. So I wanted to talk about that briefly. So I've been saying for a while that because, in fact, let me share the other screen for a second. So I've been saying for a while that countries like South America, in fact, let me go to Data Explorer. So there's many countries in South America that are out of control right now. Their season right now is winter because they're the southern hemisphere. So it's winter time for them, and we know that the R value goes up in winter. People stay indoors more, and winter is the typical seasonal time for flu and other respiratory illnesses. And so we're looking now for South America to see what our winter will look like. And so I've been paying close attention to Chile, Panama, which is not quite South America, Peru, Brazil, for a couple of reasons. The problem is the data coming out of those countries is atrocious now. So for instance, if you look at the number of tests, or the share of positive tests, let's say, Brazil, 83% of the tests that they perform are coming back positive. So that means you can't interpret this, because it means that the only way you would get a test result so high is if they're only giving the test to people who they're already pretty sure are positive, and then they're almost just using the test as sort of like a final confirmation or something. And so right now we have no idea how many people are actually positive because they're not testing. So it's unfortunate for us because we could be using these countries as really good lenses for us. If we had a really good sense of the number of people that were infected in each of these countries, then that would tell us what the herd immunity threshold is, because as soon as the numbers start to come down, we'd have great insight into what the herd immunity threshold is. Unfortunately, the data is so poor right now. There's a couple of things, like confirmed deaths. Look at this. So Peru, no, that wasn't that. Let's do it per million because that's easier to see. So Peru was going on one curve, and then last week, the number of deaths dramatically went up to, and it just a random day. And it turns out that there was a new person in the public health who started a new role in Peru, and they realized that the reporting was abysmal. Particularly, there's a lot of remote areas, and in these remote areas, they're just not doing any testing or reporting. People are dying. They're not reporting any of it. And so they came on board, and they're trying to do a better job of reporting. But this was just a single day. And so we don't know, are they catching up? Were those deaths over a few days? We don't know. But clearly, this is hitting Peru really hard. But so interestingly, I've been trying to dig into this from some of my friends who are in South America, who are epidemiologists working on this. And there was an interesting study that just published that I would like to share with you. And that is this. So this is really hard to see, so I apologize. I just took a screenshot of it. This was all I could find. It was in Spanish, so this is the Google Translate version of the Spanish. The key takeaway is this. I'll just read it right in the center of the screen. The key takeaway is under the results section, right here. So between July 13th and 18th, 700 homes were visited, and so they randomly tested each of the people who lived in those houses. So we're assuming a pretty random test. So it wasn't a convenience sample. It was statistically strong, methodologically well designed to try to truly identify how many people have been infected. And so here they estimated that approximately 71% of all the households in this area of Peru had been infected. So unfortunately, some people have been talking and saying, well, maybe there could be herd immunity that could be achieved. The herd immunity threshold could be achieved at 20%. But in Peru, where it's, again, winter time here, this is 71%. So what it means is that we're probably not looking at herd immunity at 20%. We're not looking at herd immunity at 40%. It's probably in Peru closer to 70%. And this is not the end. This was just this 1 week. The epidemic is still ongoing. So that means it's at least 70%. We know that once you have herd immunity, there's still an overshoot because it's less likely that more and more people get infected, but there are still some people that continue to get infected just at a lower rate. And so it could be that ultimately before this is done in parts of Peru, over between 70 and 80% of people are ultimately infected. And again, the fatality rate is approximately 0.65. And that would give, if this turned out to be the case in the United States, which it won't for a variety of reasons now, we have better treatments that we're doing, getting people diagnosed early, preventing people, and particularly with the new treatments and the new vaccines that will be coming out, it's highly unlikely that we'll get this many deaths. But based on the original, if this were 1910 and this infection we're just starting to spread now, then that original estimate of around 2 million people dying, so based on 80% infected and the infection fatality rate I shared, that 2 million would have probably been spot on. And again, this study is just from this past week. And so this is a serious thing that we still have to deal with. A lot of us have high confidence that the vaccines and the treatments are going to be very effective that we start to see over the coming months. And so, I mean, so that's going to be great. But the flip side of it is that this is not something we can just let burn out on its own, because it's not going to. All right, let's go on to the next thing. All right, so that's, all right, so I'm gonna end it with this, and I'll just dig into this. I'll spend a few minutes digging into this. The question of the death rate. So around 1/3 of Americans believe that the COVID-19 death toll is less than officially reported. Back in May, they believed it was around 23% of Americans believed that it was a conspiracy and that people were overwriting, that too many healthcare people were saying that the cause of death was COVID, when really someone just walked in with a heart attack, and the conspiracy is that people walked in with a heart attack, they might have been co-infected with COVID, and they were listed up, it must be a COVID death. And so there's this vast conspiracy. Almost 1/3 of people in America believe this conspiracy that the number of reported deaths are too high, that the actual deaths are far lower, and that the reported deaths are just coincident or just for some reason over-reported. Maybe the hospitals get paid more to report a death that's COVID. And so in contrast, among epidemiologists, we are all certain that the deaths are underreported, and I'll get into that in a second. And so in terms of Americans, roughly 1/3 of Americans, and I hope everyone who's listening to this understands or will understand in the next few minutes why the actual death toll is far higher than what the official number is that's reported. But roughly right now, roughly 1/3 of Americans believe that the actual death toll is higher than what is actually reported. So before I go into some of these questions and really dig into it, I wanted to share with you a news article, or a bunch of news articles from Texas over the last week. So this is a refrigerated truck to store dead bodies. This one is a smaller one that we're looking at here. They come in different sizes, but this is not being reported on in the news a lot. People are not talking about this, and so it seems like we read that, oh, there's more cases in Arizona and Texas and whatnot, but we don't actually realize that there's people's mothers and fathers and sons and daughters and brothers and sisters who are being impacted by this disease. And so this is a smaller one. Let me show you the other one. This one is a bigger one. This truck stores 50 bodies. And one Texas county alone, this was Hidalgo, repurposed repurposed 5 of these in the last week or two. So each one stores 50. This is not normal. The morgues are beyond capacity and they can't process the bodies. Like the crematoriums here in parts of Texas have a 2-week waiting period because they can't process the bodies fast enough. And so they have to use these trucks. This is what New York City was doing at the height of our hospitalization when people were dying and they had nowhere to put the bodies. In Texas now, this is becoming more widespread. This is where we are now. The deaths are real. They are not being underreported. We are not reporting enough of them. And so let me dig into some of the specific questions that people might have. So did the lockdowns cause deaths in addition to preventing COVID deaths? Are there more cancer deaths now? Like, so the one question was, well, maybe the lockdowns kept people from getting diagnosed with cancer because they were staying home, they weren't getting the normal diagnosis they would have had. Are we seeing more cancer deaths now, like in June and July, than you would have expected because none of them were diagnosed in March and April? And some other people are saying, well, maybe the 80-plus-year-olds who died in March, April, and May, they were already the sickest of the sick, and maybe they would have died anyway. So that's what this argument going that, well, the people who had a heart attack, the COVID was just coincidental, and they had a heart attack, they would have died anyway. And so, and another way of saying this, some people are saying is, well, maybe they were the sickest of the sick, they would have died in a few months, and they're just they just die a few months early because of COVID. And so maybe that's why there's so many more. But in the course of the year, maybe you wouldn't see any more deaths because you're only just having a lot of people die a few months earlier than they would have. And so I want to dig into these questions a little bit more because they're really good questions and we do have some good answers on them right now. So let me flip back here. All right, so I'm going back to this one. All right, so anyone can go to this website. This is the CDC's website. They're tracking specifically, I don't know what the link is here. Oh, it's a long one. So just look for excess deaths associated with COVID by the CDC. All right, and so if you flip down here, there's a lot of really interesting ways to look at this. So here's my favorite way. I'm gonna update the dashboard. All right, whoops, that's not what I wanted. All right, so this in green, what we're looking at are the actual number of deaths that are reported. And so you can see this goes back to January of 2017. You can see that there's seasonal variation in total deaths. In some months it spikes. So this was due to flu in 2018. This orange number, you see that there's a gap between, let me make this a little bit bigger. You see that there's a gap between the orange and the green. And so the green tells you an expected number. And the expected number in this month was this week ending January 26th. The average expected deaths was 61,000. The upper bound, the orange upper bound, was 64,000. And the number of actuals, the best estimate, was, they call it predicted, but it's the best estimate of the number of deaths that week was 58,000. So there were a little bit less deaths that week than you would have expected in a normal, just all things being equal every year, and it was far less than what this orange is. The orange is sort of like exceeding 95% confidence intervals, so it's really far out. The expected again is where the green number, if this were the surface of the volume, then it would be sort of like the surface, and then the orange is sort of like statistically significantly different. So we do look at statistical significance. Here, what we found early on is that the country as a whole had a lot more deaths than what we're seeing now. So this is great. A lot more deaths. It's great now that we're not having as many deaths in most cases as we had early on. The problem is when you start digging into the data. So this is what you do see the green, that there were a bunch of excess green deaths early on. And so these are cases that would have been COVID but were mislabeled. And so let me dig into some of this because it gets really interesting. I'm going to look at New York City as a case study. All right, so here's New York. It has very consistent deaths when you look back January 17, January 18. Here is where it was back in March, April, May. You still had some continuing death through, oh wait, this is September. Oh no, this is July 4th. Pay no attention to this. This is all white space. So the most recent is July 11th. So it's currently, I'm recording this, it's July 26th, but the most recent data is July 11th. So we still don't have a lot of visibility over the last couple of weeks. They do mention that only 60% of death records are submitted within 10 days of the date of death. So it's really, the completeness is a real issue. But when you start looking back in time, you can see a lot. And one of the key things is there is no other explanation for all of this green above the orange, except that it's COVID that was mislabeled as COVID. In fact, we can dig into it a little bit more, but there is a lot of the death that reported, rather, let's put it this way. Among the deaths that were reported, that was only a fraction of the total deaths, because you see a fairly sizable percentage of it were actually not reported as COVID deaths, even though they are clearly statistically significantly outside of what you would have expected. So there was an epidemic going at this time. And so we can break this down into really interesting ways in New York City. One way that we can do this is by total number by cause of death. So in New York City, let's go in New York City. So in New York City, it's interesting, most of the cause of death that was excess during that time. So this includes both COVID. So I like this way of looking at it because it includes excess death that was due to COVID and excess death that was not necessarily labeled as COVID, but was still identified as an excess death. And so they looked for each of these different kinds of ways of dying, how people died. And the biggest one by far was ischemic heart disease. And so ischemic heart disease, if you break that down, is heart attacks. So myocardial infarction and other things like that. And so what this means is we've been talking for a while. We know that COVID is a clotting disease, and it impacts the lungs for sure, but it's at least as importantly a clotting disease as anything else. And it is causing a lot of heart attacks, and a lot of them are just being labeled regular heart attacks or regular myocardial infarctions and are not being thought of as being caused by COVID, when in reality it is the COVID that's driving a lot of this excess that we're seeing. You're seeing, when you look at things that were labeled as typical influenza or other respiratory illnesses, it's actually not a lot more than what we would have expected in previous years. You are seeing some, but people are ultimately dying from these other things. Strokes, not nearly as much as the myocardial infarction. Cancer, this was really interesting. And so this is cumulative since February, when this, so taking a step back before anything might have happened, cumulative since February, there were not a lot of cancers, excess relative to what you normally would have predicted. And in fact, what I want to show you even more, which is so interesting, is weekly number of deaths by cause. So let me come into New York City again. So here is this idea. So this goes back to that one of the questions that I had that I'm responding to now. And that's the question of, well, maybe the lockdowns did more harm than good because people had cancer and they weren't diagnosed because of the lockdowns. So maybe in March and April and May, the lockdowns, people weren't getting diagnosed. And so now you would see a spike in cancer diagnoses or deaths even from the cancer. But in reality, now we can track it for more months, and you see that there's been no increase in the cancer. There's no spike. And so it's roughly consistent with the average that you would see any other year with cancer deaths. And so this is really good news in the sense that the shutdowns didn't cause more cancer deaths. Good news. So we can put this to rest. You see, if there were more cancer deaths, you would have seen a spike in New York City. and we did not see the spike. New York City had a strong lockdown. We can look at New Jersey too. New Jersey had a lockdown. The data, the data is a little bit more messy, you see, but they're a little bit more noisy. But even here, we had the lockdown, and then it's all within a regular average of a regular season. It's all staying within the gray. What we did see are more circulatory disease deaths and more respiratory deaths. Exactly what we would have expected. There were some other types of diseases that were impacted. I can dig into that a little bit more. All right, so within respiratory disease, you can see some were labeled influenza, pneumonia, some were chronic respiratory disease, lower were impacted, and that was the source of death. Other diseases of the respiratory system. If we look at other select causes, so diabetes had a spike, that went down. There's still some lingering COVID that's around, and so there's still some lingering fatality associated with that. Renal death had a little bit of excess early on, but now it's getting back to normal. And sepsis was, again, this idea of sepsis. So it's when you have your system goes out of control with this infection around the body. This was a early issue, but now it's again coming back to just regular seasonal variation. So it's not like we've sort of people who were meant to die a few months later were just sort of like died a few months earlier because of COVID. This hypothesis is totally false. There's no data that supports this anywhere. What I do want to go and look at is now some of the hotspots that we looked at. So for instance, Arizona. Let me go back here. All right, so we saw this earlier for New York City, and we saw, oh, New York City was basically, they weren't actually telling the truth, the whole truth, in terms of how many deaths there were. Well, guess what? Here we have Arizona. And Arizona, we think, oh, look, it's doing so much better. They're really not, the cases seem to be going down, the hospitalizations seem to be going down, and the deaths aren't so bad. Well, guess what? When you dig into the deaths, you can see that among the blue ones are the ones that are reported, almost as many deaths are unreported, but that are almost certainly due to COVID. Again, the orange line here is the 95% confidence interval. We have to pay attention. See all the white space? I can't really point. Every time I come down to it, the white box comes up. I can do it on this side, I found. So all this white space over here, this is the expected value, is what the top of these green lines are. This is what the expected value is each month or each week. I think this is weekly data. The orange line is like, you have to be way excess in order to hit that threshold. Then it's very statistically significant, and you can see that it's not just variation, because you might get variation on a week-to-week basis. Some weeks you might have a lot, some weeks a little. Like, so for instance, see how there's this one that just stood out? Yeah, it was significant on this one week, but most are not that. So it's just variation from week to week that is mostly what you're looking at. But this is not variation week to week. This is clearly a trend. The trend goes back all the way to, what is this? Back to March, April, May. You can already see that the expected value would have been, 1,200. The upper bound threshold, the orange, was 1,360, and the actual number was around 1,300, a little bit more than that. And so these numbers, the green probably would be, if I were to look at the predicted here, whoops, it's hard when I'm in so close. So if I look at the predicted, the most recent week is a little hard to interpret, again, because it takes, there's a delay in the death reporting. It is July 10th, or July 11th. There are still a couple weeks between then and now. But if we go back a couple weeks before that, let's say June 27th, you still do see at least a couple hundred death delta between what you would have expected versus what is actual there. And yet, in terms of the reported deaths, it's only a tiny fraction of that. So, I mean, if I were to just, let me stop this and go back for a second. So this is what we were looking at a little earlier. So this is Arizona. So Arizona here, back in June, was reporting to 30 deaths a day. And we were seeing far more than that actually from COVID. And here, the most recent, it's hard to know, this is July 23rd. So if we look back a couple of weeks, July 11th would have maybe been around here. Let's call it 50 or 60. Let's call it 60. 60 deaths, let's say, was what they reported July 11th. Again, July 11th, 60 deaths. That's far different than, I hope I have to share my screen. Far different than July 11th, what we're seeing here, where we already know that if the expected number of deaths was 1,160 and the actual deaths was 1,560, that's a 400 person difference. They reported 60, although I think that that was 60 per day. This is 400 per week. Okay, so that's a major difference. But even still, this is quite a lot more deaths than what they're reporting. And so this is major. And so again, this proves that there's underreporting, significant underreporting. If you look at Texas, Texas is not having as many deaths as we saw in Arizona right now, but still, when you look at the proportion, a lot of the deaths that they're having are not being reported. So when we're looking at the COVID deaths, they are not accurate. The problem is that this is even worse now than it was back in March and April. In March and April, there was so much uncertainty. It was the fog of war. New York City should have known better, but we didn't have our act together. But now the fact that these states are not diagnosing these people who are dying, there's no excuse for it. It's just terrible. The one other thing I wanted to point out, I think I mentioned this earlier. I'll just go back to this. It's number of deaths by age. And so this goes to this question of, let me go to New York City in particular, because the problem is when you look at the national level, not all the states were impacted equally. And so as a result, it's not the same. And so let me just show you one last thing and then I'll end it here. So there is this hypothesis that the people over age 85 were the sickest of the sick. Some people were saying they would have died anyway, and so they're the sickest of the sick. And so if that were the case, you would have expected that in the weeks following that you would have had less 85 years and over dying, because they would have almost been culled out earlier, that the sickest of the sick would have already been dying. What we're seeing here instead is that it's gone back to seasonal normal. And so the seasonal average rate of death among people 85 and over is now back to where you would normally expect at a seasonal level. There has been no dip. Let me go in a little bit closer. See, no dip. This is the seasonal average. So this hypothesis that it's the sickest of the sick that are dying, that's not the case here. These were lives cut short. Some people are saying, well, because some people who have multiple comorbidities are higher risk of dying, that those are the ones who are now just died earlier. And this is not the case. You would have seen this red line continue to go down and then come back up at some point, because these people would have just died, let's say, a few months earlier. That's not what we're seeing. It's seasonal death. These were truly lives cut short. And so hopefully that has answered all the major questions here. I recommend you look at the site in more detail if you want. Again, just Google excess deaths, COVID, CDC. With that, are there any questions before I end it tonight? Any questions, anything you want about excess death that you'd like me to dig into a little bit more? I hope that the answers have been clear here, because the data, this is not just a perspective, like the data is really clear here at this point. All right, if that's not it, any questions, I'm gonna stop presenting.
Glenn, can we talk next week about schools?
Absolutely.
Since that's definitely a big concern.
Yeah, there's no easy answers for schools. I talked about it, I think 2 weeks ago on YouTube. I went into some detail. No, I could share it with you again.
Okay.
But there's not a lot of easy answers. In particular, so Israel reopened. They're a good case study. They reopened with schools, and then they found a major outbreak that came as a result of reopening, and they found that it was increasing spread in the community. but we can dig back into that. We can talk about universities for sure. Great.
Okay, thank you.
Thank you, everyone. Have a great week. Talk to you next week, 7 p.m. All right, bye-bye.